Uro surgery, urinary tract diseases, symptoms of urinary tract diseases, pain, renal pain, character, dull constant aching pain, site in the renal angle between the sacrospinalis and the last strip, referral to the anterior renal point at upper outer quadrant of the abdomen, cause, renal pelvis distension or to stretch of the renal capsule, ureteric or renal colic, character, colicky pain, site and referral extends from the loin to the groin when the stone is just coming out of the kidney, localized to loin, and as the stone moves downwards, pain is felt in the groin and may radiate to the upper thigh and to the scrotum in males or the vulva in females. When the stone is impacted at lower end of the ureter, symptoms of vesical irritation and pain refer to the tip of the penis. Associating symptoms, nausea and vomiting, cause, acute obstruction by stone, leading to distension and increased ureteric muscular contractions called peristalsis. Vesical pain, character, it's different from slight discomfort to severe agonizing pain with severe desire to micturate, expulsion of just few drops of urine, site, in the suprapubic region, especially with full bladder, referred to the tip of penis, causes, cystitis, bladder stone, or bladder carcinoma. Prostatic and seminal vesical pain, character, deeply seated vague discomfort, site, in the penis, referred to perineum, rectum, or suprapubic region, cause, usually due to inflammation. Urethral pain, character, burning, cause, urethritis, occurs during micturition. Testicular and epididymal pain, site, scrotum, radiation to lower abdomen or costovertebral angle, cause, epididymal orchitis, trauma, or torsion. Dull ache may be caused by varicocele. Systemic symptoms, symptoms of infection, fever, malaise, and headache in pyelonephritis and pyelonephrosis. They has rigors in addition. Symptoms of metastasis, malaise, weight loss, back bony pain, and symptoms related to the involved organ. Symptoms of renal failure, malaise, nausea, vomiting, fatigue, forgetfulness behavior, behavioral changes, loss of weight, loss of libido, headache, pruritus, and bleeding tendencies as epistaxis and melena. And then we're gonna go to symptoms related to micturition. Symptoms of bladder irritation causes infections as cystitis and prostatitis by stone, and these symptoms include frequency of micturition, urgency, strangury, dysuria. Dysuria, definition, painful urination which is related to acute inflammation of the bladder, urethra, or prostate. Associated symptoms, urinary frequency and urgency. Strangury, definition, persistent desire of urination and straining and micturition with painful passage of few drops of urine which may be blood-stained. Urgency, definition, strong sudden desire to urinate, cause irritability of the bladder by obstruction, inflammation, or neuropathic bladder disease. Urge incontinence, patient is able to temporarily control urine, but loss of small amounts of urine may occur. And then frequency of micturition. It may be day, diurnal, or by night, nocturnal. Causes, bladder irritation and cystitis, diurnal and nocturnal, and bladder stones, diurnal. Mechanical reduction of bladder capacity, such as large bladder, tumors, or bladder fibrosis by TB, radiation, and schistosomiasis. Functional reduction of bladder capacity, as in patients with prostatic enlargement due to presence of a big amount of residual urine, which leads to nocturnal frequency. Polyuria, definition, increased urine production by the kidneys, causes excessive drinking or uncontrolled diabetes. The normal bladder capacity is about 400 milliliters. Prostate enlargement, benign or malignant, and urethral stricture are common causes of bladder outlet obstruction. Then, symptoms of bladder outlet obstruction. Hesitancy and straining, difficulty in micturition, loss of force and reduced caliber of the stream, terminal dribbling, interruption of urinary stream, sense of incomplete emptying, and retention of urine. Retention of urine can be acute and chronic, sense of incomplete emptying due to presence of residual urine, terminal dribbling more noticeable as obstruction progresses, loss of force and reduced caliber of the stream, noted with high urethral resistance despite increased intravesical pressure, difficulty in micturition. In benign prostatic hyperplasia, patient has to relax at the beginning of micturition, hesitancy, while patients with urethral stricture have to strain to pass urine. Hesitancy and straining, the early symptom, definition, delay in initiating the urinary stream. Continuing symptoms of urinary system diseases, urinary incontinence, and symptoms related to changes in urine. Symptoms related to changes in urine include changes in urine volume, changes in color and content of urine, changes in urine volume, polyuria, oliguria, and anuria. Polyuria, excessive fluid intake, diabetes mellitus, diabetes insipidus, and high output chronic renal failure. Oliguria, urine volume less than 400 milliliters per day in adults, causes acute renal failure due to shock or dehydration or bilateral ureteric obstruction. Anuria, one of the urological emergencies. Definition: urine volume less than 200 milliliters per day, causes pre-renal, renal, and post-renal. Pre-renal causes as shock and dehydration. Renal causes as toxins, drugs, and renal diseases. Post-renal causes as bilateral renal obstruction or complete obstruction in a solitary kidney. Changes in color and content of urine. Hematuria, passage of blood in urine. Pyuria, presence of pus in urine, microscopic or macroscopic. Chyluria, presence of lymphatic fluid or chyle in the urine, appear white milky. On adding ether, urine clears, and on adding Sudan-3, it gives orange discoloration. The main cause is phleresis. Cloudy or turbid urine due to presence of excessive phosphate crystals, phosphaturia, which precipitate in alkaline urine. Adding few drops of acetic acid clears the turbidity. Necroturia, pathognomonic of bladder carcinoma. Definition: passage of pieces of necrotic tissues in urine. Pneumaturia, presence of gas in urine, cause mostly as fistula between urinary tract and colon, and that's caused by malignancy of the colon or bladder or by colonic diverticulitis. Urethral discharge, one of the common complaints in men, causes urethritis, particularly the gonococcal type. Associated symptoms: burning micturition. Bloody ejaculation, hemospermia, cause inflammation of the prostate or seminal vesicles. Infertility, varicocele may reduce sperm count and motility. Mumps or chitis may cause testicular atrophy. Sexual difficulties in men, erectile dysfunction, premature ejaculation, and loss of desire. If anuria is due to stones, it's called calcular anuria. Infection can cause urine to be cloudy and malodorous. Examination for urinary tract diseases. General examinations. Signs of chronic renal failure may be present, such as pallor from anemia, eye puffiness, dry tongue, abnormal breath odor, dehydration, convulsions, abnormal respiration, abdominal distension, edema of lower limbs, drowsiness, tremors, hypertension. Abdominal examination may reveal a mass or fullness in the renal angle or suprapubic area. Genital examination in males, look for ulcers, meatal stenosis, hypospadias, epispadias, discharge, swelling, hydrocele, and varicocele. In females, vaginal examination. Digital, rectal, or bimanual examination, DRE, to feel anal sphincter tone, walls of anal canal and rectum, prostate for size, normally 4 cm in length and width, nodules consistency, normal it's rubbery, tenderness, and mobility. Seminal vesicles, normally not filled. Schistosomiasis lead to calcification and they become palpable. Urinary bladder tumors are felt. Malignant deposits in the rectovesical or rectouterine pouch. Differential diagnosis of renal mass: hydronephrosis, pyenephrosis, polycystic kidney, renal tumors such as hypernephrome or Willem's tumor, big renal cyst. Investigations for urinary tract diseases: laboratory, imaging, and finally we have, there's nothing after imaging. Laboratory, urine analysis midstream. 4. Physical properties, biochemical analysis, microscopic examination and microscopic staining, culture and antibiotic sensitivity, and finally cytological examination. So, physical properties: color, normally amber yellow. pH, normally acidic, ranging from 4.5 to 7.5. Specific gravity, normally from 1005 to 1040, according to hydration state. Biochemical analysis for albumin, glucose, and bilirubin. Microscopic examination for crystals, casts, and cells. Crystals as oxalates, uric acid, phosphates, and cysteine. Casts as hyaline, granular, and epithelial. Cells as RBCs and YBCs. Bilharzial ova and sperms. Microscopic staining for pyogenic organisms, such as by gram stain, acid-fast or Zell-Nelson stain for TB. Normal urine contain less than 5 RBCs and YBCs per high parafield. Epithelial cells are present in normal female urine. Culture and antibiotic sensitivity, and finally cytological examinations for malignant cells. Urethral discharge analysis and culture for gonorrhea and chlamydia. Renal function tests. Blood urea, normally from 15 to 40 mg per deciliter. It's not an accurate test. Blood urea nitrogen, or called BUN. It's normally from 12 to 15 mg per deciliter, and it's more accurate. Serum creatinine, this is the best, normally from 0.2 to 1.5 mg per deciliter. Creatinine clearance test, normally from 70 to 140 mm per m. Serum electrolytes, serum potassium is elevated in renal failure. Serum PSA, prostatic specific antigen, for a diagnosis of prostate cancer, normally it's 4 nanograms per milliliter. Imaging, ultrasound, abdominal and pelvic ultrasound advantages. They are simple, cheap, non-invasive technique, provides information about morphology, site and size of the kidneys, as well as thickness of the renal parenchyma, diagnose obstructive uropathy, dilated pelvic calcaneus system, differentiate between cystic and solid lesions of the kidney, bladder tumors can be visualized, estimate the amount of post-voiding residual urine, transrectal ultrasound, very accurate in diagnosis of prostatic lesions, and it allows guided biopsies from suspected prostatic cancer. Plain X-ray of urinary tract, known as plain UT or KUB. The following findings are looked for, such as soft tissue shadow of the kidney enlarged with renal swellings, psoas shadow obliterated by perinephric abscess, bony skeleton. Look for spina bifida, wide separation of sensitive pubis. In cases of ectopia vesicae or fractures and bone metastasis, radio-opaque shadows, urinary stones, renal, ureteric, bladder, and prostatic, abnormal classification of the urinary tract as that of renal TB and renal tumors, bilharzial bladder and calcified bilharzial seminal vesicles, honeycomb appearance, calcifications outside the urinary tract, adrenal calcification, mottled calcified lymph nodes, stapes mesenterica, calcified iliac vessels, and pelvic fleboli. And then we have intravenous pyelography or IVP or intravenous urography, IVU, idea. Take X-ray films after IV injection of radio-opaque, iodine-containing contrast material called urographin, and the contrast is concentrated and excreted by the kidneys in urine. Normally, a nephrogram phase appears within a few minutes, then pelvic calcaneus system, later, ureters and bladders are visualized. Afterwards, the patient micturates and post-voiding film is taken to evaluate residual urine, which is normally almost zero. Advantages: show most of congenital traumatic inflammatory and neoplastic lesions of the urinary tract, gives idea about functional capacity of the kidneys. Creatinine clearance test means the amount of plasma completely cleared from creatinine by the kidneys in 1 minute. It denotes qualitative kidney function accurately. Iodine contrast media are allergenic, and that's why precaution sensitivity testing should be done. Infusion urography indications: patients with impaired renal function where IVU will not show up due to lack of secretion of contrast medium. Method: contrast material is mixed with saline and then infused slowly over a period of 15 minutes to allow kidneys to concentrate contrast. Contraindications: blood urea is more than 100 mg per deciliter. Retrograde or ascending pyelography indications: when data obtained from IVU are not conclusive, or if IVU is contraindicated, such as uremia or contrast sensitivity. Method: cystoscope ureteric catheters are passed along the ureters to the renal pelvis and a contrast material is injected. Advantage: provides good delineation of the pelvic calcaneus system but no information about the renal function. Cystography types: descending cystography and ascending cystography. Descending cystography: during performing an IVU, the bladder will be visualized in late films, but the pictures may not be of high quality as the contrast is diluted with urine. Ascending cystography: urethral catheter is passed to the bladder and 400 milliliters of saline mixed with contrast is infused. Indication: identify bladder pathology or vesico-ureteric reflux. Urethrography indications: diagnose urethral injuries, strictures, or fistulous tracts. Types: micturating urethrography during IVU, ascending urethrography by injecting contrast medium through external meatus. CT scan uses: currently of choice for detection of urinary stones, staging of renal and bladder neoplasms, and assessing urinary tract trauma. Can be supplemented with contrast injection. Disadvantages: involve high radiation dose. MRI advantage: not involve radiation or iodide contrast media. Indications: staging of neoplasms and assessing venous involvement in renal cell carcinoma, plus evaluation of renal artery stenosis. Renal arteriography indications: diagnose renal artery stenosis and renal tumors and for kidney donors before transplantation. Method: selective catheterization of the renal artery by cannula through the femoral artery using Schlesinger technique. Radioisotope scanning. Types: we have DTPA, diethylene tetramine, and pentaacetic acid. It's called renogram. The isotope is rapidly excreted through the glomerulus. The radioactivity is traced by the use of gamma camera. Triphasic curve is plotted describing vascular phase, secretory phase, and excretory phase. Vascular phase, in which the isotope reaches renal vasculature. Secretory phase, it's filtered by the kidney. Excretory phase, it leaves the kidney through the ureters. Indication: diagnosis of renal artery stenosis and obstructive uropathy. DEMSA, or dimer-captosuccinic acid. Idea: isotope is concentrated in renal tubules as only 5% is excreted. Static kidneys images obtained 3 hours after injection. Indications: demonstration of renal scarring, which results from chronic pyelonephritis, focal defects as tumors and hematomas, lacerations, and ischemia. Both types of radioisotope scanning are attached or labeled with technetium 99 milli, and both are given intravenous. In obstructive uropathy, administration of furosemide after isotope accentuates abnormality in the third phase of the curve. Endoscopy. Advantage: great accuracy visualization of the urinary tract. Uses: both diagnostic urethropy, cystoscopy, ureteroscopy, and nephroscopy, and therapeutic purposes. Any suspicious lesion is biopsied. Urodynamic studies. Advantages: study physiological functions of the bladder, urinary sphincters, and urethra. Indications for patients with neurogenic bladder and incontinence include cystometry and flowmetry. Cystometry measures bladder volume against intravesical pressure. Flowmetry measures the amount of urine passed per time unit. It's the most important non-invasive and useful urodynamic test. It's commonly used to diagnose lower urinary tract obstruction as senile prostatic enlargement, urethral stricture, and neurogenic bladder. The normal urine flow rate should be more than 20 milliliters per second, provided a good amount of urine is voided and not less than 120 milliliters. Retention of urine. Definition: inability to pass urine in spite of full bladder. The commonest causes in males: senile prostatic enlargement and post-operative retention. Retention is much less frequent in females. Residual urine in SPE collects in the post-prostatic pouch. Differential diagnosis: anuria. Definition: absence of urine or urine less than 200 milliliters per day. The bladder is empty, in contrary to retention, where bladder is full and forms a median pyriform swelling in the suprapubic area, dull to percussion. Etiology: mechanical causes and functional neurogenic causes. Mechanical causes: urethral, prostatic, and bladder. Urethral: injury, phimosis, urethritis, stricture, and stone. Prostatic: prostatitis, abscess, senile enlargement, and cancer. Bladder: bladder neck obstruction, stone, and cancer. Compression from outside by pregnant uterus or pelvic tumors. Functional neurogenic causes: spasmodic and atonic. Spasmodic in post-operative cases, particularly after anal surgery, acute retention. Atonic in diabetic autonomic neuropathy and coda equina. Types: acute retention, chronic retention, and chronic retention with overflow. Acute retention. Definition: acute painful inability to pass urine despite the presence of the desired void. Chronic retention. Definition: the patient voids, but residual urine remains in the bladder. The amount gradually increases, leading to full bladder. As the bladder distension is gradual, only little discomfort with hesitancy and reduction of force of stream is present. The high volume of retained urine, leading to high intravesical pressure and impaired kidneys drainage. Chronic retention with overflow. Definition: bladder is full with large amount of residual urine, and urine passes when vesical pressure exceeds the urethral pressure. Constant dripping of urine occurs, leading to paradoxical incontinence. Clinical picture: this type is painless and the bladder is not tender. Effect: produces back pressure on the upper urinary tract. Treatment: acute retention. The following measures are done in sequence: conservative treatment, including analgesics and getting out of bed. Warm bath is advised. If no organic obstruction, as post-operative retention, injection of parasympathomimetic drug as carbachol or Dorel. Catheterization. Indications: failure of conservative treatment. Catheter used: soft catheter, Nelaton or Foley's catheter. It may be removed or left till treatment of the cause. Percutaneous suprapubic catheter or cystocath. Indications: failure of catheterization. Technique: under local anesthesia, puncture urinary bladder through abdominal wall in the suprapubic region, then introduce catheter. Treatment of the cause as prostatectomy. If there is no back pressure effects on the kidneys and renal functions are normal, there is no need for catheterization. For chronic retention, treatment of the cause and catheterization. Catheter used: self-retaining Foley catheter. Indications: back pressure on kidneys or elevated renal functions, slowly evacuation to avoid bleeding from prostatic veins or renal decompression bleeding. The cause is investigated and treated later. Urinary incontinence definition: uncontrolled escape of urine. Types: total incontinence, stress incontinence, urge incontinence, overflow or false incontinence, enuresis, and fistula. Total incontinence definition: urine loss without warning. Etiology: secondary to defective urethral sphincters as ectopia vesicae and sphincter injury after prostatectomy. Stress incontinence definition: urine loss in association with physical strain, such as coughing, laughing, and straining. Incidence: common in multiparous women with weak muscle support of the bladder, neck, and urethra. Urge incontinence definition: involuntary loss of urine present with desire of micturition. Cause: acute cystitis and an upper motor neuron lesion. Overflow or false incontinence definition: involuntary dribbling of urine due to chronic retention or secondary to flaccid bladder. Occurs when intravesical pressure exceeds the urethral resistance. Enuresis: bed wetting at night. This is physiological phenomena during the first 2 to 3 years of life. If it persists, this may be due to functional, secondary to delayed neuromuscular maturation of the uretrovesical component, or symptom of organic disease as neurogenic bladder. Fistula definition: abnormal communication between urinary and gynecological organs, like vesicovaginal and uretrovaginal fistula. Etiology: it follows obstetric trauma. Hematuria definition: passage of blood in urine. Types: frank or microscopic, more than 3 RBCs per high power field on urine analysis, painful or painless, and in relation to urine stream, it's divided into total hematuria, terminal hematuria, and initial hematuria. Total hematuria definition: passage of blood all through the stream, source from the kidney, or from massive vesical bleeding. The blood clots from the kidney would be cylindrical, and in vesical bleeding it's rounded. Vesical means from the bladder. Common causes: stones and tumors. Terminal hematuria definition: passage of blood at the end of micturition. Source: pathology in trigone, bladder, neck, and sometimes senile prostatic enlargement, prostatic piles. Common cause: schistosomiasis. Initial hematuria definition: passage of blood at the beginning of the act. Source: urethra. Etiology: general causes, renal causes, ureteric, bladder, prostatic, and urethral causes. Urethral causes: urethritis, urethral stones, urethral injuries, neoplasm of urethra. Prostatic causes: senile prostatic enlargement and prostate cancer. Bladder causes: urinary bladder stones, tumor, inflammation, non-specific bilharzia or tuberculous cystitis. Ureteric causes: ureteric stones, surgical and instrumental procedures on the ureter, neoplasm of the ureter, transitional cell carcinoma. Renal causes: renal stones. Congenital causes as polycystic kidney, inflammatory diseases as acute glomerulonephritis and TB. Traumatic, accidental, post-operative, post-instrumental. Neoplasm of the kidney, hypernephroma, transitional cell carcinoma, and Willem's tumor. Vascular causes as renal infarction. General causes: anticoagulant therapy. Hemorrhagic blood diseases as thrombocytopenic purpura or hemophilia. Painless hematuria without other symptoms, silent, regarded as a symptom of tumor until proved otherwise, usually intermittent. Hematuria from kidney is usually associated with cylindrical clots, while hematuria from the bladder associated with discoid clots. Common causes of hematuria: urinary stones, most common, UT injuries, urinary tract injuries, renal tumors and bladder tumors, schistosomiasis. Differential diagnosis: other causes of red-colored urine are from dietary causes, red beetroots, coloring agents in cakes, cold drinks, and fruit juices, drugs as furadentine, rifampicin, laxatives which contain phenolphthalein, phenolphthalein. Hemoglobinuria definition: passage of hemoglobin in urine. Etiology: it occurs with hemolytic states. Evaluation: the cornerstone is a thorough medical history, directed physical examination, and urine analysis. For low-risk patients with microscopic hematuria, renal ultrasonography and urine cytology. For patients with gross hematuria or risk factors, urine cytology, cystourethropy, contrast-enhanced imaging of the kidneys and ureters, IVP or CT. Risk factors for significant urological diseases are age more than 40, cigarette smoking, history of exposure to possible carcinogens, and finally, pelvic irradiation. Congenital anomalies of the urinary tract, development of the urinary tract, kidney, pelvic calcareous system, and ureter. A ureteric bud arises from the lower end of the mesonephric or Wolffian duct, grows upwards retroperitoneally. This bud forms the ureter, and its upper end will form pelvis, calyces, and collecting tubules, excretory elements. The upper end of the ureteric bud will be capped by metanephros, forming glomeruli and nephric tubules, secretory elements. Later, nephric tubules establish continuity with collecting tubules, ascent and rotation. Kidney starts development in the pelvis, then it ascends to the loin. As the kidney ascends, it also rotates. At first, the pelvis lies anteriorly and the calyces are posteriorly. Later, pelvis rotates to lie medially while the calyces face laterally. Urethra. The urogenital sinus forms the whole urethra in females, posterior urethra in males. The inner genital folds form anterior urethra in males, tip of glans penis epithelium invagination leading to glandular urethra. Wolffian ducts from the trigone form the trigone, ejaculatory ducts, and vas deferens. Anomalies of the kidney classification. Anomalies of ascent leading to ectopic, pelvic, or iliac kidney. Anomalies of rotation, incomplete rotation. Anomalies of renal vasculature, aberrant and accessory renal arteries, vessels, renal artery aneurysm and AV fistula. Renal dysgenesis and cystic disease of the kidney, hypoplastic simple renal cyst, polycystic kidney, multicystic kidney, medullary sponge kidney. Anomalies of number, agenesis, bilateral or unilateral, or supranumerary. Anomalies of the shape, form, and fusion, horseshoe kidney, discoid or cake-shaped kidney, sigmoid and L-shaped kidney. Anomalies of the renal pelvis, bifid pelvis, which is double pelvis, pelviureteric junction obstruction. Simple renal cyst, pathology, it may be solitary or multiple, unilateral or bilateral, mainly confined to the renal cortex and don't communicate with any part of the nephron or the renal pelvis. Clinical picture, commonly asymptomatic, renal mass if the cyst is huge, intermittent dull aching pain in the flank or back, complications, hemorrhage or infection, they are acute symptoms. Differential diagnosis, renal cell carcinoma, renal abscess, complex renal cysts, those which contain blood, pus calcification, septation, irregular margins or clusters of cysts, require further investigations, CT or MRI. Treatment for asymptomatic cases, no treatment, just follow-up. If the cyst causes symptoms or hydronephrosis due to renal or ureteric compression, treatment options include percutaneous aspiration plus injection of sclerosing agents or surgical excision of the cyst wall, marsupialization. Complex cysts such as hemorrhagic cysts, thick wall or cloudy fluid, surgical exploration and excision. Polycystic kidney, we have the adult type, which is autosomal dominant, and it's only one type. Adult type autosomal dominant incidence, the common form of cystic disease in the kidney. It affects both kidneys, responsible for 10% of cases of end-stage renal failure. Almost 50% have associated liver cysts. Liver function is normal. Cyst of the lung, pancreas, and other organs may be found. Intracranial aneurysm present in 30 to 40% of the patients. Pathology, the cysts don't form before the age of 10 years. Grossly, kidneys are enormously enlarged, with surfaces studded with cysts of various sizes. On section, the cysts are scattered throughout the parenchyma. Cyst fluid, usually amber clear, and they may be hemorrhagic or infected. Clinical picture. For the first 10 years of life, no symptoms because kidneys are normal in function and anatomy. From 10 to 30 years, still asymptomatic, but ultrasound show presence of the cyst. After 30 years, the patient may develop UTI, macroscopic or gross hematuria, flank pain, hypertension, and palpable kidney. Between the age 40 to 50 years, renal function impairment, urea and creatinine start to elevate, and after the age of 50, renal failure. Investigations, we have laboratory and radiological. Laboratory, urine examination, RBCs or pus cells may be present, blood urea and serum creatinine elevated. Radiological, ultrasonography or CT scan, accurate in diagnosis. Excretory urography with infusion shows enlarged renal shadows and bizarre calcial pattern, spider leg appearance as the calces are stretched over the cysts. Treatment before renal failure and after renal failure. Before renal failure, controlling hypertension by antihypertensive medications, treating UTIs by appropriate antibiotics, low protein diet, and regular check of the renal functions. If a large cyst compresses the pelvis or upper ureter, by percutaneous ultrasound guided aspiration, persistent heavy hematuria, embolization. After renal failure, we have renal transplantation, which is a definitive treatment, hemodialysis, temporary measure until suitable donor is found. Horseshoe kidney, pathology, fusion occurs early in embryological life when kidneys lie in the pelvis. Ascending is arrested by the isthmus being blocked against the inferior mesenteric artery, and then normal rotation will not occur because renal pelvis lies on the anterior surface of the kidney. Ureters ride over the isthmus, which connects lower poles, so angulation of the ureter as it crosses renal isthmus, and ureteric obstruction, stasis occurs, favoring infection and stone formation. Clinical picture: 1/3 of the patients are asymptomatic. Symptoms of complications such as pain, hematuria, or fever. Hydronephrotic horseshoe kidney, palpable below umbilicus. Investigations: IVU, kidneys are lower in position, lower poles are nearer to the midline than at the upper poles, lower pole cases point medially and lie medial to the ureter, leading to flower vase appearance. Undiagnosed hydronephrotic horseshoe kidney may be excised by mistake in an exploratory laparotomy, and it's very serious. Before excising such a mass, always check for the presence of the kidneys by ultrasound or by IVU. Treatment indication only for complications: division of the kidney isthmus, rarely required. Aberrant and accessory renal vessels. Single renal artery is noted in 75% to 85% of individuals. Rarely, aberrant arteries arise from vessels other than aorta or main renal artery. Accessory arteries arise from the aorta or main renal artery. If one of these arteries pass to the lower pole of the kidney, may obstruct the ureter, leading to hydronephrosis. Division of an accessory artery leads to infarction of the corresponding portion of the renal parenchyma and arteries. On the contrary, aberrant renal vein can be divided without effects. And this concludes our part for the urosurgery for today.